The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Hello, yes, and thank you for that introduction, and thank you to Daryl for asking us to speak today. Naomi was supposed to be here with me, but she's decided to go to Scotland instead. So this is actually from both of us, because we run the liaison service at Frankston Hospital together. I've been a critical care liaison nurse for the past 8 years, and during that time, that motley crew and I have looked after thousands and thousands of MET calls. We primarily run at Frankston Hospital, which is the main campus of Peninsula Health, and we've got about 420 beds, 105 of which are ED and mental health beds, but we still cover those. Our team consists of 2 nurse practitioners, so myself and Naomi are the nurse practitioners. We have 3 CNCs, and at the moment we've got somewhere between 5 and 8 CNSs that are rotating in and out of the role for leave, with Naomi away at the moment. And obviously our bread and butter, like most liaison nurses, is ICU discharges, rapid response calls and direct referrals. I don't know about you guys, but this winter has seen 2 of those go by the wayside, and all we do is rapid response calls at the moment. So very, very quickly, because everyone's slightly different at their hospitals, we run a code blue. We have 2 kind of code blues, well 3 if you count the airway. One is an out-of-area emergency. So for people in outpatients departments, visitors that have tripped over the front step, anybody who's collapsed in the front, can't find where the new emergency is and so they come to the wrong entrance, they call a code blue, and it's considered an out-of-area emergency, but the code blue team attends. It is incredibly time-consuming, and 99% of the time we put them in a wheelchair and take them to ED. If they're over in the Frankston Integrated Health Centre, which is sort of a separate building and a dialysis patient, if I can't get them in a wheelchair safely, I have to call an ambulance to take them 30 seconds around to the ED department. Again, incredibly time-consuming, but we feel that we have a duty of care to anybody visiting our hospital. Obviously, the other code blue is a cardiopulmonary arrest, no response, no breathing, no circulation, and if you want an anaesthetist, you call a code blue airway. MET calls is an inpatient response, and since Naomi and I have become nurse practitioners, we are the ICU representative. So there's always a medical registrar. When Naomi and I are there, which is usually Monday to Friday, we can guarantee that we're on the early shift, and then on weekends it kind of changes. It's the ICU registrar only attends after hours or when one of the other CNCs is on. Or if they're not on, then they go with an ICU nurse. So when the nurse practitioner on, it's just 2 of the MET calls. This is just a snapshot of some of the numbers that we've had, and I'm sure that yours look very similar. It's lovely to see that our code blues have gone down. I'm sure it's down, as our MET calls have gone increasingly up. And last month we had over 303 rapid response calls for the month, which was a new high for us. So we actually have a lot of influence, both nursing and medical, across the ward. We work very closely with all parts of the multidisciplinary team, and we attend a lot of formal and informal education, and we're also heavily involved in the consultative processes. So we're actually really lucky. The liaison team at our hospital is the consistent part of the rapid response system. We can have a different medical registrar every day, and it usually changes week to week as well, and the ICU registrar, usually you'll get the same one during the week, but not always. Orientation day, this has already come up. We always try and grab the graduate nurses, graduate midwives, interns, HMOs, residents. We've got a little spot at all of their orientation days. We break it down into practical information. We obviously give them statistics, and we talk a little bit about our service and how we can help them. We like to give statistics because it does scare them, and let's face it, that's fun. What we do try and do, though, is we have a shared mental model, and any time that we do education with anybody, we try and use this slide so that everybody has a bit of an idea about what we would expect them to behave at the MET call. And it saves the confusion because, I don't know about you, but sometimes going to a MET call you can't find the patient for the amount of people in the room, particularly if you've got students and medical students, and that's lovely, but sometimes it makes it very, very difficult to do your job. So if everybody's got a little bit of an idea what they need to do, that makes it so much easier for us. I'm not going to read through that. I'm sure it's very similar to what you guys do, but it certainly helped us when we're educating particularly new registrars who are coming to MET calls with us to have a bit of an idea about what the expectation is for them at the MET call. We also go to registrar training, and we have multidisciplinary simulation days with the MET-Call and the Code Blue scenarios, which are fantastic fun. And we are heavily involved with the ICU registrars. Even though we are a standalone service, we work very closely with the intensive care team, and we always work closely with the ICU registrars. If we're out at a MET-Call by ourselves and we want backup, we're very blessed to Monday to Friday have a consultant B on, who's on for wards and admissions, referrals and so forth, and they're able to come and either give us a hand, give phone information, same for the ICU regis if they're on the wards, but that makes it so much easier to then take responsibility for those patients knowing that we have that backup. We also are involved in basic education, so basic for nurses, basic for doctors and beyond basic, mainly again with the deteriorating patient, ALS, BLS and non-invasive ventilation. We've just recently become involved in PROMPT, which is a multidisciplinary obstetric emergency education days, again clarifying rapid response processes. You know, when is it appropriate to call a blue, when is it appropriate to call a MET? Sometimes midwives, particularly now that we're having direct entry midwives and less people who've got both qualifications, general and midwifery, and highlighting specific rapid response call issues that can happen for the obstetrics. When we first started 8 and a bit years ago, we had a lot of requests for education, and as MET calls have become more and more and we're seeing sicker patients, we have a lot of calls for education on our time. It got to the point that we really couldn't produce the education. We were giving monthly lectures and then we were asked to go to in-services and, you know, ward meetings and handover time, and it just was unsustainable. So with the Education Department at Frankston, we developed what's called the Deteriorating Patient Study Day, and it's a 4-hour day and it's run quarterly. It's multidisciplinary, although the nurses are the ones that do tend to utilise it, and it's for all campuses. And we do teach at that course. We do take time to try and teach at that course, as well as help update it every year. However, I reckon informal education, certainly from a liaison point of view, is where it's at. This is when we're at patient reviews, we're at rapid response calls and the direct referrals. We're role modelling for patients. This is where we tend to find we do the majority of our education, particularly for interns. If it's not time critical, therefore if the patient's not peri-arrest and you've got a little bit of time on your hand, maybe they can do the ABG, or maybe they can, it's a very collaborative approach. Even though the ICU representative in our hospital policy-wise is considered the lead at MET calls, Naomi and I take the stance that it's a very collaborative approach. We usually have a med-reg there, and if it's a medical team, then the med-reg usually isn't needed, and we've got the medical team there. If it's a surgical team, we really hope that the peri-op med-reg rocks up because she's a great help. But it's a collaborative approach, and everybody's doing, not doing the same thing. Everyone's taking their own little role and we're talking together. Obviously, if it's time critical or it's a code blue, then you have one person in the lead, or if it's becoming a bit disastrous, then we tend to take over. Phone consultations are not ideal. However, with us all getting busier and busier, and our hospital, probably like yours, is just getting further and further apart the more buildings they make, I often can't get to 3 things at once, and I'll be at a MET call and I don't know what it is. Do you guys have this at your hospital where nobody else hears the MET call thing except for you who's on the MET call? So I'll be doing an ABG and someone rings me for bariatric cannulas for their resus trolley. Do you get that at your hospitals? Like, nobody else hears it. I'm like Pavlov's dog. I was at Monash and I stood up because they've got the same chimes as me. But phone consultations are really important, and oftentimes we can actually pick up patients from those phone consultations that would normally not have come across our radar and could potentially have deteriorated and MET called in 24 hours' time anyway. So we find them very important. Most of the time it's questions about, is this compatible, and then we try and lead them back to, you know, looking it up for themselves. I think a lot of liaison services have done what we've done, and we have created a little bit of an over-reliance on our service, and sometimes people just find it easier to pick up the phone and call us than find out themselves. And so we're in the process now, and for the last sort of 12 months, because we just can't sustain what we've been doing, pushing back a little bit and sort of sending people off to where they should be looking for that information. The consultative process, so the admin start of it, we started the Standard 9 when it was Standard 9, now it's Standard 8. We chair the Deteriorating Patient Committee if needed. We consult and develop relevant policies and CPGs. We obviously benchmark with other liaison services and other nurse practitioners at Peninsula Health and also nationally. So into the future, we've been really blessed at Peninsula Health to have become nurse practitioners. So Naomi and I became nurse practitioners 2.5 years ago, and 18 months ago the hospital actually created the role for us. So what that means is that we actually released the ICU registrar back to the unit during the ward round, and I know that our ICU consultants think that's fabulous, because otherwise the ICU registrar did not know what was going on in the intensive care ward round, didn't know the patients, didn't know what was happening, knew all the met call patients outside of the ward, but didn't actually know what was going on in the unit, and it made it very, very difficult to actually run the unit. So we've found personally that that's been really good, and I'm trying to think, I haven't actually once this year asked for an ICU reg to come out and help me, because we've got the consultant backup. If things are that scary, usually we need the consultant anyway. So Naomi and I have obviously done our Masters of Nurse Practitioner, and we've got advanced assessment skills. We've both been nursing for over 25 years and in ICU for about 20 years. And so we do our own respiratory interventions. We also run the non-invasive ventilation service at Frankston. While our antibiotics aren't on our formulary, and that was by choice, we do help with the junior doctors with prescribing and things like that. Obviously pathology and radiology and sort of some nursing interventions. So 18 months into the role, we've released the ICU registrar back to the ward rounds. I'm not sure that they would cope now if they had to come out all the time, although for the last month we had the A consultant, the B consultant, the senior reg, the junior reg and the liaison nurse all at different met calls at once. So I'm not sure how we're going to do that in the future. We are the consistent person at a met call, so 99% of the time we might actually know that patient, we might have heard conversations, we might have been at family meetings, we could have a little bit of information that maybe other people don't have when they go to the met call. So that's something that's really nice to be able to have that backup when you're at a met call and it's time critical. We're in the process of actually doing a research project looking at the first 12 months of the liaison practitioner and how the outcomes for patients that have just been seen by us and just been seen by the ICU registrar are unchanged, basically. And we're looking to hopefully implement some succession planning in the future. So some training topics that I would really like to invest in the future for the guys, because they all know their ABCDE and you can go over it several times in the Compass program, and there's so many things out there, and I agree with not reinventing the wheel. I'd like to talk about the appropriate use of NIV on ward patients. For some reason, just because we seem to be doing it on end-stage COPD patients for the 24 hours. That turns into a week because nobody's got an exit strategy once you get them on NIV. Unfortunately, we've got a lot of people altering the met call criteria and thinking that that's okay. I've had a few come on in the morning, you know, heart rate greater than 170 till 8 o'clock in the morning. It's like, oh, interesting. Oh, look, there's the met call. So people seem to be turning off the alarm but not realising why the alarm's there, and I think we need to do a lot more work into that because that's becoming a big problem in our hospital, and I'm sure we're not alone. And again, there'll be lots of work done on this during the concept, recognising the dying patient, the futility of medical treatment. I had a consultant say to me the other day of a patient obviously dying in the bed, we're going to do a trial of life for 24 hours. I said, I'm sorry? So the patient died 6 hours later. No morphine on board because we were doing a trial of life. So I think that's something that we all recognise as a big problem, and I think that the rapid response team, like it or not, are heavily involved in that, and we will be into the future. So thank you.